السلام عليكم ورحمة الله وبركاته. طلاب مرحلة الثالثة كلية طب جامعة نيسان. معكم دكتور حيدر سعدون قاسم consultant physician, continue with infectious diseases, and today we'll talk about infections caused by helminths. Infection caused by helminths, nematode or round worms, intestinal human nematode, Encylosoma duodenale, Necator americanus, Strongyloides stercularis, Ascaris lambricoides, Tropius vermicularis, and Trichuris trichiuri. Zoonotic nematode, which means come from animal, Trichinella spiralis. To start with, Encylosoma duodenalis, or hookworm الديدان الشصية. This is the life cycle of the worm. This is the larvae, this is the ova, the site of interest from the bare food, and from the bare food goes to the portal circulation, from which to the lung, and from the lung to the pharynx, bronchi, lung, causing eosinophilia, and cough, duodenum, adult worm, and eggs pass in the stool. Pathophysiology: encylostomiasis caused by parasitization with Encylosoma duodenale or Necator americanus. The adult worms about 1 cm in the duodenum, the upper part of jejunum. Eggs are passed in the stool. They penetrate human skin and are carried to the lungs. After entering the alveoli, they cause a second alveoli. They ascend to the bronchi and swallow and mature in the small intestine, reaching maturity within 4 to 7 weeks. Each worm suck about 0.15 ml, and this is Encylosoma duodenale, while Necator americana suck about 0.03 ml each day. Each worm. Hookworm infection is one of the main cause of anemia in the tropics and subtropics. Encylosoma duodenale is endemic in the Far East and Mediterranean area and is also present in African, while Americana is present in West, East, Central America, and Central and South of America, as well as Far East. Clinical picture, clinical presentations: allergic dermatitis, usually on the feet, a site of entrance, ground itching, may be experienced at time of infection, passage of larvae through the lungs, causing paroxysm of cough, could be blood stained, associated with patchy pulmonary consolidation, and eosinophilia. Whenever you say eosinophilia, it means eosinophilic count in the blood more than 5%. When the worm have reached the small intestine, vomiting and gastric pain resembling peptic ulcer may occur. Sometimes frequent loose stool are passed. Feature mimic malabsorption syndrome. This is the electron microscopical picture for Encylosoma duodenale. This is the tooth of the worm, and this is the second part of the duodenum, and look to the worm hatch and attached to the surface of the duodenum. Clinical feature continue. The degree of iron and protein deficiency developed depend not only on the load of the worm but also on the nutrition of the patient. Patient with good nutrition, no problem, looks healthy. Patient with marginal nutritional status, it will appear on him feature of malabsorption, iron deficiency, anemia, and even protein malnutrition. Anemia with high output cardiac out failure may result because the anemia in those patients is chronic, slowly developing. The mental and physical development in children may be affected. There is eosinophilia count more than 5%, the differential count, tomato blood. The characteristic ovum can be recognized in the stool. If hookworm are present in numbers sufficient to cause anemia, fecal occult blood test may be positive and many ova will be present. So fecal occult blood can be positive in patient with Encylosoma duodenale whenever they have large worm infestation. Single dose of albendazole 400 mg treatment of choice. Alternatively, mebendazole 100 mg 12 hourly for 3 days may be used. anemia and heart failure associated with hookworm infection respond well to oral iron even when severe blood transfusion is rarely required. Second worm, Citrongyloidiasis. Citrongyloides stercularis is very small nematode, 2 millimeter, which parasite the mucosa of the upper part of the small intestine, often in large number, causing eosinophilia. The eggs hatch in the bowel, but only larvae pass in the stool. After penetrating skin, undergo development similar to that of hookworms, except that the female worm burrow into intestinal mucosa and submucosa. This is the larvae, Strongyloides stercularis. Some larvae in the intestine may develop into filariform larvae, which may then penetrate the mucosa or the perianal skin and lead to auto-infection. Auto-infection, whenever you use your finger to relieve itching in the perianal area, there will be repeated infection or auto-infection. The patient infect himself. Patients with citrongyloidiasis infection persistent for more than 35 years have been reported. Citrongyloidiasis occur in the tropics and subtropic and especially in the Far East. Clinical feature is classical triad of abdominal pain, diarrhea, and urticaria. Why urticaria? Because the female larvae move in the subcutaneous tissue. Urticaria highly characteristic and occur in 70% of patients. Citrongyloidosis hyperinfection syndrome occur with dissemination of larvae throughout the body, occur in association with immune suppression, intercurrent disease, HIV, viral infection, or steroid use. Patient presented with severe generalized abdominal pain, abdominal distension, and shock. So systemic presentation of citrongyloidiasis occur in patients with immune deficiency. Massive larva invasion of the lung cause cough, sneezing, dyspnea. Cerebral involvement could be manifestation of the disease. Gram-negative sepsis frequently complicate the picture. There is eosinophilia, more than 450 microliter. Strong serology for ELISA is helpful. The feces may be examined microscopically for motile larva. There is no ova, only larva. Larva can also be found jejunal aspirate using string test. Larva may also be cultured from feces. A string test involves swallowing of a string to obtain sample from the upper part of the small intestine. يعني المريض مبلع مثل الخيط وبي مادة بالنهاية يبلعها عادة بالليل. الصبح نسحبها ونلقى اللارفا hatch أو attached to the lower part of the string اللي هو الخيط عادي. The sample is often tested to detect the presence of intestinal parasite. The treatment, ivermectin, 200 mg per kg, a single dose, or 2 doses of 200 mg per kg on successive day is effective. Alternative to ivermectin is albendazole, orally 15 mg per kg per body weight, 12 hourly for 3 days. Second course may be required. For hyperinfection syndrome, ivermectin is given day 1, 2, 15, and 16. Let us talk about the third worm seen in clinical practice, usually seen by surgeon mainly. Why? Because constant obstruction. Roundworm, Ascaris lumbricoid. The pale yellow nematode is about 20 to 35 centimeters, so it is too long. Humans are infected by eating food contaminated with mature ova. Ascaris larvae hatch in the duodenum, migrate through the lung, the same life cycle, and descend to the bronchial tree, swallow and mature in the small intestine. Pneumonitis, eosinophilia, eosinophilic granuloma, bronchial asthma, and urticaria may occur. Clinical feature, intestinal ascariasis cause symptom ranging from vague abdominal pain through malnutrition. Whenever you have large size of the adult worm and its tendency to aggregate, it can cause intestinal obstruction, as seen by this picture. This child presented with abdominal pain, repeated vomiting, and absolute constipation, feature of intestinal obstruction. tropical and subtropical area are endemic for ascariasis. It goes up to 35% of all intestinal obstruction, most commonly in the terminal ileum. Investigation, the diagnosis made by microscopically by finding the ova in the feces. Adult worms are frequently expelled rectally or orally. The worm can be expelled from the nasal or from oral orifice, and even from the anal. Occasionally, the worms are demonstrated radiographically by barium examination. Also, there is eosinophilia. Management: single dose of albendazole, 400 milligram. Parenteral palmitoids, and this is the dose for parenteral palmitoids. All these antiemetic. Patient should be warned that they might expel numerous whole large worm. Obstruction due to ascariasis should be treated with NG tube, piperazine, and intravenous fluid, and rarely they might need surgery, as I show you in the previous pictures. Prevention: WHO recommendation that community chemotherapy program have been used to reduce ascaris infection. The whole community can be treated every 3 months for several years. Alternatively, school children can be targeted, treating them lower the prevalence of ascaris in the community. We stop here and continue in the next lecture. Thank you very much.